Good afternoon and welcome to the IDEPI seminar series presented to you by the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health. I am Bene and I'll be your moderator for this week. And today we're delighted to have with us Professor Marcia Castro. She's an Andelo Professor of Demography and she's also the chair of the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. She is also the co-director of the Brazil Studies program of the David Rockefeller Center for Latin American Studies. Just a few standard logistics before we start. The seminar is being recorded, so please turn off your camera if you do not wish to be recorded. The recording will be available on our website at a later point in time and will be on YouTube as well. After approximately 45 minutes, we will stop for questions. Throughout the talk, you can send your questions via the chat function to James Hay. You have the possibility to ask your question to Professor Castro directly. So if this is the case for you, please notify James in the chat. And we will ask you to turn your camera and we will unmute you as well once we are ready to take your question. So coming back to our presenter, Professor Castro earned a PhD in demography from Princeton University. She is a founding member of the Scientific Advisory Board of the Wittgenstein Center for Demography and Global Human Capital. She also serves as a member of various Brazil studies programs at Harvard. Her research involves the use of multidisciplinary approaches to identify the social, biological, and environmental risks associated with the transmission of vector-borne diseases and inform control policies. She is involved in malaria control programs and projects in Africa and South America, and studies specifically the malaria poverty vicious circle, as well as the impact of urbanization on malaria transmission. Since the beginning of the pandemic, she has been very active in the COVID-19 response in Brazil. She is a member of an observatory that monitors daily cases and provides guidance to policymakers. She collaborates with the Brazilian Ministry of Health and also does a lot of public engagement. And you can find some of her interviews on the school's website. She will talk to us today about the COVID-19 response in Brazil. Thank you very much for joining us, Professor Castro, and please take it away.
Thank you so much for the invitation. And what I plan to do today is to go over four main things. Briefly, I'm going to give you a little bit of the challenges Brazil faced to address COVID-19, but also the opportunities that the country had to actually do a really good job. I'll tell you a little bit about how the response was and has been. And then I'll focus most of the time discussing the outcomes and some of the analysis we've been doing in trying to understand how the disease has been spreading across the country. And I'll have a few reflections at the end of what is expected to come next. So in terms of context, really the place to start is with the social determinants of health. And here, Brazil checks many of those boxes. Brazil is a highly unequal country, so it had many challenges in order to be able to respond to the pandemic. That also raises the issue that if Brazil wanted to do the right thing, they had to put together a response plan that addressed those inequalities in order to provide a response that was targeted to those vulnerable groups. Very briefly, some of those issues in Brazil are related to access to infrastructure. So just one example is access to water. About 84% of the country has access to water, but that varies a lot. It's above 90% in the more developed center-south area of Brazil, but in the Amazon region, it's about 57%. We also have several settings, particularly in urban areas where you have the sort of slum type of areas with very poor ventilation, crowded houses, no access to infrastructure or very limited access to infrastructure. So places that not only are conducive to this type of virus to proliferate, to spread really fast, but also those people have no conditions of working from home. A lot of them depend on informal labor, or even to self-isolate if they had exposure, because it's impossible for them to self-isolate considering the very crowded households where they are. The number of physicians per population and hospital beds per population is also very unequally distributed across the country. Here in this map, all those dark areas are municipalities in Brazil that have no ICU beds. And just to give you one example, this state here is Amazonas. That's where the capital, Manaus, that was all over the news, and I'll talk more about it, is right here. The only municipality in this state that has ICU beds is Manaus. It's a huge state, right? But it's the only one that has ICU beds. So the distribution is not equal. And in here, you can see the distribution of hospital beds that are the public ones. So that people that have that only use the public system have access to, not equally distributed as well. And I should mention it's about 75% of the population in Brazil that solely depends on the public system. Comorbidities that are provide a higher risk for mortality due to COVID. They have a regional pattern as well and a socioeconomic pattern as well. I bring you only one number. It's a number that came out late last year. It's the numbers on obesity and overweight in Brazil. 60% of the Brazilian population is overweight. 26% is obese. And this number increases with age and also is more prevalent among people with low socioeconomic status. Brazil had an economic recession in 2015. It had not recovered from it. So poverty and inequality were increasing when COVID came. So it's sort of a perfect storm that was cooking, just from an economic point of view. And all the issues about racism in a different context from the ones we've been discussing in the US, but they're also present in Brazil. So inequalities, social determinants of health, big challenge, not impossible to address, but a big challenge. The second one I want to mention is actually a combination of two. On the one hand, it's all this issue of infodemic, misinformation, disinformation. And here, I think what makes Brazil not unique, because this also happened in the US, but it's that the leadership of the country is propagating some of those fake news, some of this disinformation in many different ways. So it's not just the social media or other channels, WhatsApp, but it's also the people right at the top making decisions that are also propagating that. And I'll mention a few examples in a moment. And the other thing is the polarization of the society. So it's so polarized. Again, that's not unique in Brazil, but it's so polarized that a simple decision that should be a public health measure, use a mask, it's not a public health measure, it's a political statement. And about 5 days ago, the president of the country was speaking to the country. He has those videos that he records, and he was basically saying that there's scientific evidence that masks should not be used because you get headaches and a bunch of other stuff that it's not even worth repeating. So that's the kind of a second big challenge in terms of the context. Now, despite those difficulties, Brazil had different opportunities, and I'll mention four things to actually do a good job. So the first one is Brazil had time to plan. So Brazil could see what was happening in other countries. We knew it was going to come to Brazil. It was just a matter of when it was going to arrive. So we had time to plan, taking into account those inequalities, those challenges. And I just want to mention here, this was very different from when Zika virus hit Brazil, that Brazil had no time to plan. Brazil was the first one. They had to make decisions. They discovered all the consequences to the pregnant women, to the newborns. It was unfolding in the country. COVID was completely different, right? This time was not really used. The second thing I should mention, which is a huge advantage Brazil had compared to other countries, is that Brazil is really the only country with more than 100 million people that has a universal health system free to anyone in the country. And it has one of the largest community-based primary care programs in the world, with community health agents that live in the community where they serve most importantly, because of that, they know the people that have comorbidities because they follow people with diabetes, people with cardiovascular conditions. They follow the children. They know the houses that are overcrowded, that don't have water. They have all of that through the network of community-based primary care. That not only wasn't used, but the health system enters the pandemic completely underfunded. On the one hand, historically it has been underfunded, but with the economic recession, there were many austerity measures imposed in the country that basically froze the budget for health. So not an opportunity that was leveraged either. The third thing I want to mention, and this is really important, Brazil has phenomenal scientific institutions and researchers. And I could give you many different examples. I'm going to give you only one. So the day the first case was diagnosed, 48 hours, less than 48 hours afterwards, the entire genetic sequence of the virus was done by a group of researchers in Sao Paulo, led by a woman. I should mention that. So Brazil is producing high quality research. The institutions are getting together in collaborations, despite the fact that the federal government is basically attacking public universities, attacking researchers, and denying all the scientific evidence that is being produced. The fourth and last thing I want to mention, which is also an opportunity, is the entire historical legacy that Brazil has in responding to public health emergencies. None of those are perfect, but they were great in itself. And there is a historical one. I'm not going to spend too much time on this, but Brazil was the first country that decided to really eliminate yellow fever. It was successful, urban yellow fever, I should mention. It was successful, and then they decided to eliminate the vector, Aedes aegypti, and they did it. And in 58, the Pan American Organization declared Brazil free of Aedes aegypti and modeled the Brazil program and really got rid of the mosquito in the Americas, with the exception of the US, who never wanted to join the campaign, Venezuela, and parts of Guyana. So of course, the mosquito is back now. We have dengue, Zika, chikungunya. The list is just keeps growing. But it was this campaign that inspired an elimination program that was successful, that Brazil basically spearheaded. And a more recent one is the response Brazil gave to the HIV/AIDS pandemic. And it was a model response, received many awards. And if it was not for that response, Brazil would have horrible indicators on HIV/AIDS, and that was avoided thanks to that program. So many challenges, terrific opportunities. What happened? So what happened was really a disaster. The president is sort of, a lot of people said that it's the sort of the tropical version of Trump in some way. So he really denied the importance of the disease, was always favoring economy over health, if you can actually separate those things. Some of the statements that were made are even hard to believe. We had 3 ministers of health at the time when Brazil was going through the worst moment last year. We stayed without a minister for more than 3 months. It didn't create an integrated, coordinated program to respond to COVID. There was no clear message. We don't have a communication campaign. And surprise, surprise, Brazil has a protocol that was issued by the Ministry of Health on the use of chloroquine, hydroxychloroquine, to treat COVID. So that gives you an example. People are dying, and still the president says you shouldn't use a mask. If it depends on me, there's no lockdown, and you should take chloroquine. So I think that gives you an idea of the kind of leadership we have. So in the absence of the state, of the response from the government, and on top of this, of the wrongdoing that they were, it's not just not doing anything, it's also doing the wrong thing. What we saw in Brazil was phenomenal initiatives that happened at the local level. We had groups bringing together philanthropy, the industry, private hospitals, universities that really got together and created different programs, all of them designed to help the local population. So there were apps to monitor cases and deaths. That were apps that elderly, if they had a fever, they would touch a certain thing and then somebody would come and check on their health. There was massive distribution of food, cleaning products, so different combinations. And this is great in itself, but this should be actions happening on top of the federal response. They were happening in the absence of the federal response. And I should mention, Brazil has 5,570 municipalities. 22% of them have less than 5,000 people. There's no way this can be the model of response. Again, this should be the exception in addition to what was being done. Probably all of you have heard of the Oxford stringency indices that basically check to what extent places are being very stringent in following recommendations from the WHO. Here, what you see are the federal responses that comes from the president and the Ministry of Health, and these are all other policies that were implemented in the country. You can see the gap between what was done at the federal level and the local level. This is all the country, and here I bring two examples. São Paulo, the largest. Again, that's the federal, and in São Paulo, the responses in the capital city, it started more stringent than the state, the entire state. In Ceará, which is a state in the northeast of Brazil, the measures at the state level were more stringent than in the capital, but then they sort of caught up and the federal lagging behind. So broadly, the response was and still is bad. And wait until I tell you everything that is happening regarding the vaccine. It's a complete disaster. And some people in Brazil are starting to use the word pandemicide, pandemic and genocide, homicide, whatever you want. And it looks like that. All right, so what are the outcomes? In May, I think it was May 22nd, Latin America was declared the epicenter of the COVID-19 pandemic, very much because of Brazil. So this is Latin America right here. In fact, by the end of May, if you look at the total number of deaths in the world, so this would be all of that, more than half were happening in Latin America. More recently, Europe took over, but this is the latest data that was available. So here, out of the 9,400 deaths in this week, February 15 to 21, Europe has about 3,500 and Latin America has about 2,600, but those numbers are going up. Brazil has been number 2 in deaths in the world since June 7, and I don't think it's gonna move at all. I hope it's not gonna go to first place, but it's not gonna come down to anything below second place. So how the disease really is spread in Brazil. So there is one of the early studies showed use genetic data, took samples and did genome sequencing, and it identified more than 100 different introductions in the country, 76% of them from Europe. And the period that they analyzed of those samples was between February 22nd and March 11th. And based on the genetic sequencing and the flights and information on mobility, they identified 2 different phases of spread in the country in the beginning. So the first one, until March 21st, the spread was mostly locally inside the borders of states. So it all started in São Paulo, and there were a few cases, but they're happening most inside states. On the second phase, then the movement starts to be long distance, with virus getting out here of São Paulo and of the Southeast region, and then hitting Ceará, Manaus, and other capitals in the northern part of the country. Now, what is interesting also to see is how the introduction happened in cities. And I'll bring you here one example. This is Fortaleza, the capital city of Ceará state. This is in the Northeast. It's the 5th largest city in Brazil. So this is the first 26 days when the first case was detected. And most of the cases are happening in those two neighborhoods of the city. Those are the two wealthiest areas in Fortaleza. And the pattern of introduction were people that had traveled to Europe, came back infected. In the next 11 days, what you see is you still have a lot of cases here in the rich neighborhoods, but you start to see cases popping up in the periphery. Well, the tricky thing is that those people were sick, but they didn't let people working for them to stay home. So they didn't isolate themselves. So they have drivers, cleaners, and you name it. And then those people started to get infected and bring the disease to where they live. Now, this is cases. Oops. Sorry. It's thinking. Apologies for that. Okay, that doesn't look good. Okay, I am gonna restart. Apologies for that. Sorry.
No worries.
I'm not sharing my screen, am I?
No, not yet.
Okay, sorry about this. Okay. All right. Okay, can you see my full screen?
Yes.
Okay. So, all right. So then, so this is the number of deaths. And if you look at what's happening with deaths is that the deaths are happening mostly in the periphery, not among the rich. This pattern basically characterized what we saw in many countries. We saw this in the US. So any epidemic, pandemic illuminate the inequality. So it's the most vulnerable, the most disadvantaged, the Black, mixed race, those are the ones dying, not the rich. This also happened in other places. It happened in Sao Paulo, it happened in Rio. It's a pattern that repeated in many different cities. Okay, if we look at the epidemiological curves, so here cases, we are in the middle of a mess, and I'll mention more of this in a moment. These are the number of deaths. What I really want to call your attention here is that those curves for Brazil, for the entire country, they're really meaningless. Here, Brazil had a phase that every day we had more than 1,000 deaths per day. And a lot of people are saying, well, Brazil reached a plateau. So my point in here is that that's not a plateau. That's actually a certificate of incompetence of stopping the virus to propagate to other areas. And this is what I wanted to show you. Each line in here is a state in Brazil. We have 27. Each column is an epidemiological week. So what you see, if you take the deaths, if you take the plateau, that's the plateau. It's the disease moving to other areas because the policies or the lack of policies are not containing the disease are not containing the cases and therefore not containing the deaths. And then it moves across the country, moves to the interior. And then that's what creates this kind of a shape in the curve for both cases and deaths. Okay, so the idea is really to look data with a more detailed lens, and the geographic lens is really important here. That's another way of looking at this. This is hospitalizations. This is in-hospital death. North region picks up first. That's where the Amazon region is. That's where Manaus is. Northeast picks next. Central West. The Southeast is where São Paulo, Rio, the big cities, it remained high for a long period of time. And the last one to really pick up was the South region. Okay, told you Brazil has 5,570 municipalities. Here they are. On the left, you have cases per 100,000 people. Here, deaths per 100,000 people. It's highly heterogeneous. And I mean, when you just consider the population, there is no standardization by age here in the deaths, but still you can see that some areas look that they were more heavily hit than others. So what we did is to ask the question, were there particular places that consistently had higher events, either cases or deaths, over a certain period of time? So this is what we did. We calculated spatial temporal clustering using the scan statistic. Basically what this does is it scans a window over the map, and the base of the window is a certain geographical area. The height of this cylinder of this window is time. So what we are trying to do is then to see if there are locations that consistently had high number of cases or deaths over a period of time. So a few things in here. First, deaths clustered before cases in the Amazon region, in Rio de Janeiro, and in Ceará, that state that I mentioned, which is right here. Second point that is important is that the duration of the clusters did not reduce over time. So with one of my students, we did an analysis of South Korea, use a similar method. And what we showed for South Korea is that the duration of the clusters and the geographical extent of the clusters reduced over time, which was directly connected with the capacity of the country to quickly respond and stopping a certain foci to become a large cluster and to last for a long period of time. None of this happened in Brazil. The clusters, don't be fooled by the large area. I mean, it's you have a large population in here. Some of those municipalities don't have a lot of people, but the population that is exposed in here, when you look at the relative risk, is really high. And it's not that the time that those areas remain a cluster is going down, not at all. Second thing we did was to basically ask the question, well, when are cases shifting from the capital cities and going to the interior? And here, the blue line are cases, the red lines are deaths, the solid line, capital. So everything starts in the capital cities, but soon enough, the cases happening outside capital cities really take over. And I just want to show you a few maps to give you an idea how connected this huge country is. This one, which I apologize for the low resolution, but these are connections measured by cell phones. And you can see that there is this area that looks empty. It's just we don't have enough antennas in the Amazon, so cell phones are not ideal if you're doing anything in the Amazon. But I'll show you a few other maps that will give you a really good sense of how connected those places are. And those connections were not completely interrupted. They were somewhat reduced, but not completely interrupted. So these are roads, only the main roads, and it gives you an idea of volume that is circulating. So the red is more volume. These are roads that are connection through roads, but sort of transportation that are not what we call official transportation, but you still can see there's a lot of volume. These are roads connecting internationally. So that I'm not putting the flights here, airline flights, but international through roads. And this, folks, is river. And now you can see the importance of Manaus right here. It is the main hub for a lot of connections with the other places in the Amazon region. And the Amazon River runs right through here. Okay. Last but not least, that's internal air flight. This is from 2010, so those lines are much thicker now. And the main hubs, São Paulo, Rio, Brasília, the capital, and then you can see Manaus, Fortaleza, Pernambuco, the main capitals in the northern portion. Okay, so the other thing we did then is to calculate the geographical center of the pandemic. And you can see this is moving by epidemiological week, cases on the left, deaths on the right. What you see is if you take all the cases happening across municipalities in Brazil, where is the center of the pandemic? And you can see that things shift quickly towards the north. And by the way, this is Manaus, this one right here. It shifts to the north when the northern region and the northeast region start to have a lot of events. And then it comes back to the south when the south region right here is started to have cases and deaths. So that's a good way to see how things were shifting across the territory, both in terms of cases and deaths. Next, what we did is to then find a metric that allows us to quantify this movement to the interior. And there is a measure that has been used decades ago a lot in demography, and it's called the Hoover Index. And what we used is a locational Hoover Index that basically what it does, it measures the spatial imbalance between two variables across an area. And here we're measuring the spatial imbalance between the number of people in each municipality, the population of the municipality in one state, and the number of cases or the number of deaths in that state. So the closer this number is to 1, as it was right here in the early epidemiological weeks, what it says is that cases and deaths are very concentrated in a small number of municipalities, and therefore their distribution is very dissimilar to the distribution of people in state. The lower the number, the more similar those two variables are, cases and population or deaths and population, which basically is the pattern of movement of the pandemic to the interior. Again, if you have good policies, you want this number to remain very high because you're stopping the virus to spread to other areas. So what we found is this is the number just for Brazil. I'll show you by state in a minute, but the areas here, the blue is cases, the red is deaths. The area is the highest and the lowest index found for one particular state. So it gives you a range. And what we observed is that in some weeks, for some states, the movement to the interior of deaths was faster than cases. So that's a real certificate of incompetence of stopping things to happen. Where did this happen? Manaus, Amazonas, where Manaus is, Ceará, that are the state that I mentioned. In fact, all the states in here are in the north region where the Amazon is, a few in the northeast, and the only outlier is Rio de Janeiro. And I'll tell you about Rio in a minute, but Rio was a disaster in terms of, although it has much better infrastructure, much better resources, the governor was removed from office, is facing an impeachment trial. There were 3 state health secretaries between May and September. One of them was arrested. That gives you an idea of the kind of mess it was in terms of leadership, which totally translates into also a problem with controlling the pandemic. These are some numbers for the states. Here, what I did is I did a bivariate map for the Hoover Index for cases and deaths. And that's the first week that each state had information on cases and deaths. So some of the weeks are different, but broadly, those numbers are very high, which is what you would expect, right? In the beginning, things are concentrated in small areas. Now, this is the last week. When I did the analysis, I stopped in week 41. That's early October. And there are a few things here that are really important to mention. The first one, broadly, the numbers are much lower, which reflects the movement to the interior. This state here, Amapá, in the Amazon region, was the state that at the end deaths moved to the interior much faster than cases. So the Hoover Index for deaths is much lower than for cases. And then the state that had the most intense movement to the interior was Rio de Janeiro, both cases and deaths, the top champion. And the second one was Amazonas. And then Sao Paulo also had very low numbers. So clearly what we start seeing is that there is no single narrative that can really explain the pattern of movement of cases and deaths across the territory. It's a combination of, yes, the socioeconomic conditions matter, politics matter a lot, and basically it's many different dimensions that interact and are dynamic, and then it's not a single story for each one of them. Okay, just like in the US and many other places, huge racial disparities. If you look at the risk factors for in-hospital mortality, the main risk factors are age and followed by being Black or mixed race. Indigenous populations in Brazil have 3 times higher incidence rates and mortality rate compared to the total population, so much higher risk. And here is the result of one serology study that was done in Brazil. There were different rounds of the collection. The way it was designed was to have 133 sentinel sites across the city. And I don't like to look at each point in itself because every single point there were 250 samples collected. So it's not representative. But broadly, what this map shows you is that the higher prevalence of antibodies, which are the squares, more than 10%, the purple dots between 5 and 9.9%, they're all in the northern portion. So in the Amazon region, Manaus is right here, and in the Northeast. The exceptions in the southern portion is Rio, São Paulo, and Vitória, which is another capital city in the Southeast. So what we did was to look at samples of blood donors. And what we found, we did this in this analysis for Manaus and São Paulo. We are now doing a similar analysis for 8 different cities in Brazil, also using blood donors. And despite all the limitations that using samples from blood banks may have, what we found was that Manaus likely had a very high attack rate with prevalence of antibodies around 76% in October. So here what we show is that the numbers didn't differ much when you take samples in each month from the different localities of the city, both for São Paulo and for Manaus. So this paper created a lot of fuss. Some people trash it, some people love it. And then what happened was that January came and then things start to increase again in Manaus, and everybody questioned, well, if we had such a high prevalence of antibodies, how can things go bad in Manaus? So we reflected on what could have happened, and this is basically what happened. This was the huge, very high transmission in Manaus that happened around April and May. Things, they didn't, it's not that they became great, but the numbers came down. And then here is December, and things start picking up. That's a more recent picture. So it started to decline recently, but it's still very high, higher than what it was. So we basically came up with 4 possibilities of things that were happening. And I should mention here in December, that's the first time we learned about a new variant of concern, the P1, which now they're calling the Brazilian variant. And I'll mention more about it in the next slide. So we gave 4 possible things. Either we really overestimate or it's an issue of immunity is wanting, or maybe this new variant can evade immunity and we can have reinfections, or this new variant just has a much higher transmissibility. So now after we did this, there's new evidence coming. This is a very clearly documented case of reinfection with P1. So it's a 29-year-old woman, 260 days after the first infection confirmed by PCR. She had another infection confirmed by PCR with P1. And just last Friday, we had 2 studies that came out, 2 separate groups. This is the group in Manaus. So a few things to highlight. First, of all the samples that were analyzed in November, none was P1. About 51% in December were P1. 92% of them were P1 in January. So really fast takeover. And a modeling exercise basically estimates that P1 is likely to be 1.4 to 2.2 times more transmissible than the other variants. So leads to reinfection and spreads really fast. Now, these are just 2 examples of how the news was really on fire yesterday because of those results. There is all this discussion now that Brazil may become completely isolated because of the lack of response and becomes really the birthplace for even more variants of concern to emerge. So what comes next if that wasn't enough, right? So first, I used to say it's likely, now it's pretty obvious that inequalities increased. We have 3 reports so far, one from ECLAC, one from CEPAL, one from the UNDP, all of them doing analysis, one of them with numbers already showing how the region, how Latin America is going backwards at least a decade in terms of what it achieved in reducing poverty and reducing inequality. So we're going back about 10 years on this. The second thing is we're likely to see a higher demand for healthcare. So now Brazil is basically a very red map. Pretty much every single capital city is running out of ICU beds. Some states are basically sending their patients to other states that still have beds. It's as bad as it is. São Paulo declared a curfew yesterday. Rio declared another one today. So that's the scenario. But the demand for healthcare is probably going to increase. We have all the issues on mental health. Domestic violence increased dramatically in Brazil, and those numbers are underreported, so we don't even know what are the real numbers. All the consequences of the long haulers, the long COVID, which we are still learning about them. And all of this higher demand will come at a time when healthcare professionals are completely exhausted, working at their limit, with their own mental health challenges because of all the pressure that they have been facing. And these are results of a survey that was done with healthcare professionals. That's the 3rd wave of the survey. The 4th wave is happening as we speak. So I should have more recent numbers soon. So in the face of all of that, the way out is the vaccine, right? Well, here's another chapter in the story of the response in Brazil. The president has said that he's not going to get the vaccine because the best vaccine is the virus, and he had COVID. So he thinks he's good. Well, somebody should tell him he can take another infection with P1, but let's leave it at that. The other thing I want to mention is Brazil also has a beautiful history in vaccination. At the national program of vaccination is a model. And just to give you 2 examples, in 2010, when we had the the danger of H1N1, Brazil vaccinated 80 million people in 3 months. Brazil has campaigns against polio, and Brazil vaccinates basically in a weekend 10 million children in those campaigns. So Brazil has the knowledge, the expertise, the community health agents, the network of health units in order to deploy efficiently a mass vaccination campaign. But to do that, you need the vaccines. And here, the president was offered the Pfizer vaccines first, I believe, in July last year, and 2 additional times last year he refused. Brazil has 2 vaccines, Coronavac and Oxford AstraZeneca. Janssen was tested in Brazil, right? And it would be the ideal vaccine for Brazil, one shot, no special way to store it. And yesterday, after Brazil hit another record on the second day in a row, 1,910 deaths, almost 2,000 deaths in one day, the president said that he's going to buy 100 million doses of Pfizer, so for 50 million people, and 38 million, I believe, of Janssen. Nobody knows when those doses are going to arrive. We have no idea, but this was announced yesterday. We still have to learn more. So again, Brazil has vaccinated a very small number of people. The first dose was started in January 17. Brazil has vaccinated about 3.5% of the population. That's very little. About 1% got a second dose. And in the middle of all of this, I swear it's not a joke, but the president, when he said he was not going to take the vaccine, he said, well, whoever wants to take the vaccine is their problem. And he basically implied that people could become crocodiles if they take the vaccine. So Brazilians, I have to say, we have a really good sense of humor. So immediately after he said that, there's a website that anyone can go, Jacaré Tracker. Jacaré is crocodile in Brazil. And I just got the numbers yesterday, and that's pretty much the only piece of good news I'm going to give you. Nobody has become a crocodile yet in the world. So I'll leave you with that piece of good news, and with a hug from Joe Droplet. That's probably the most successful mascot of a public health campaign Brazil has ever had. The head is a drop. That's the drop of the polio vaccine. And when Brazil does those mass campaigns on weekends to vaccinate children against all kinds of things, Joe Droplet is there welcoming the kids, and the kids love to go there just to see Joe Droplets to take whatever vaccines their mom tell them to take, and they don't complain. So, folks, that's it. I'm happy to take any questions. If I can remove this thing here, sorry.
Thank you very much for this terrific talk, Professor Castro. I think this is an amazing demonstration of how your multidisciplinary background and expertise helped analyze this very complex situation.
Are you able to stop my screen? Because I'm having issues here. Sorry.
I'm not sure I can do this, actually.
Are you a co-host?
I am. Let's see.
Sorry, this never happened, but
that's okay.
Oh, jeez, what am I doing? Oh, thank you. Yeah. Appreciate it. Sorry.
Yeah. No, that's okay. So we'll take questions now. We have about 9 minutes to take a few questions. We'll try our best to accommodate as many questions as we can. However, if your question does not get covered, please feel free to reach out to our guests directly. So the first question is from my co-host, James. The huge number of cases and deaths suggests that testing capacity has been fairly high throughout the pandemic. And so could you comment on testing throughputs and scale-ups in Brazil and how testing is handled now?
So testing in Brazil has been really limited. That's the other problem. Brazil didn't have enough tests in the beginning. And for several months in the beginning of the pandemic, we didn't have enough tests. States started to acquire equipment and also tests. So the testing capacity of the states is also extremely diverse. So the bottom line is the numbers are well, for sure, they are underestimated. It's likely that some of the deaths that are SARI underdiagnosed or non-diagnosed SARI, a respiratory disease without a clear diagnosis, some of those are also probably COVID. So Brazil had a major problem with testing in the beginning and still has problems with testing right now.
All right. And on that note, given the complex situation with testing, has any pooled testing strategy been put in place, or have people thought about using like testing wastewaters to try and estimate the amount of virus shed in communities?
Oh, that's a great question. No, what we have is we have a few research centers that are doing very detailed analysis as best as they can, but we don't have a very good genomic surveillance. So if we had, we probably would have picked up the variants earlier, and we didn't. So what we have is not at a national scale, but we have really good research groups, and they're the ones providing some of those answers, including the higher transmissibility of P1 and the reinfections on P1, but this is not at scale. So some states don't have that. Far from
Right.
ideal.
Yeah, thanks for your answer. We have another question from Jess. Could you elaborate a bit on the criticisms of the high attack rate estimates from Manaus, and why have people been critical, and how do you respond to these criticisms?
So one of the criticisms is that blood donors are not representative of the city. So what we did is, first of all, blood donors have a limited age range. So it's 18 to, I believe, 65, something like that, 60 or 65. So what we did is we used a weighting scheme in order to try to correct for the distribution of blood donors in terms of sex and age compared to the distribution of the population in the city. So we use some corrections, some weighing schemes in order to correct for that, which is quite common when you do surveys. A lot of people doing online surveys, for example, is trying to use this kind of correction. And in fact, our age distribution was actually already very similar to the age distribution of the city. The other thing that we discuss is, if anything, blood donors underreport the prevalence of diseases. So there are studies showing that if you ask what people think they have, and some studies show this for HIV, hepatitis, and a few other things. When you look at the results of the blood, and when you look at what people initially reported, usually it's an underestimate, not an overestimate. The other argument was that blood donors, maybe they are poorer, so lower socioeconomic status. We don't know that for sure, but the argument was that maybe those people take buses and they're going to get higher exposure, and therefore you're getting the people that are likely to be infected. We don't have proof of any of those things, and I still believe that the numbers are right, even if it's not 76, even if it was 50. And I should say there was another study done in Manaus that used a convenience sample. They recruited people online, and they found 56%. So, even if it's not 70 something, it's still very high. And you wouldn't, justify why you would have the peak that we have now. And just to give you an idea how bad it was, if you take the number of deaths in Manaus that were reported just this year, so basically 2 months, this is more than the total number of deaths due to COVID last year, an entire year in the same city. And if you look at Brazil, the number of deaths due to COVID reported so far is a third of all the deaths reported last year. So even if it was 50%, you shouldn't see that. So there's more to the story than, problems with the blood donors.
Great, thank you for your answer, Professor Castro. We have one person in the assistance who would like to ask their question. So Beatrice Barros, would you like to unmute yourself? and turn your video on, please.
Hi, I was wondering about sort of the increasing prevalence of vaccine skepticism and what you would attribute that to. I know that the vaccination rates have dropped even before COVID began, so I don't think it can be attributed only to, the misinformation campaign related to that.
Mm-hmm. Yeah, so there were a few surveys done showing if people were willing to take vaccines or not. Now, how much those numbers are going to play out as people see what's happening and if they're going to take the vaccine or not, I don't know. I haven't seen any numbers of, for example, has there been refusal among healthcare professionals? I haven't seen any numbers coming out from Brazil. In fact, one of the problems is that we have very little transparency on the numbers of vaccines. And just today, we are using the social networks to release a statement that was put together with the help of many different hands, exactly to complain about this. We don't know race and ethnicity. We don't know location. We know nothing. So the truth is we have no idea about how the priorities that were set for vaccination are being followed. We don't know if there are vulnerable groups that were in the priority and did not receive the vaccine. We have no idea. So maybe there is an issue, but so far, with the total lack of transparency on the vaccination data, I don't even know what to tell. I mean, I would love to know the answer, but so far we really don't.
Thank you.
Thank you for your answer, Professor Castro. I think for the sake of time, we might have to stop here.
Okay.
But there are many people in the chat box who are thanking you for your really amazing presentation and for your work. So on behalf of the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health, let's thank Professor Castro again for joining us today and for her talk, as well as the insightful answers she provided to our questions. Thank you to everyone in the audience as well for your engagement, and please do get in touch with any of the seminar organizers if you have further questions for us or for Professor Castro. Please check out the CCDD website to stay up to date on upcoming seminars and other events. Thank you again, everyone, for joining. Enjoy the rest of your day.
Thank you.
Thank you.